Bom dia a todos. Então, estamos dando início ao mais um Grand Round especial e vocês notaram que nós tivemos que fazer uma rápida modificação no Grand Round para aproveitar a visita de um convidado internacional e agradeço ao professor Luiz Augusto Rode e ao professor Goldin que cederam o dia de hoje para nós contemplarmos esse Grand Round especial. Então, é muito importante esse momento e nós vamos dar prioridade para quando nós tivermos alguns visitantes internacionais, mesmo nacionais, nós vamos tentar dar prioridade, porque isso realmente é um momento ímpar. Nós temos também hoje, através da nossa comunicação online, os nossos colegas da Universidade Estadual do Rio de Janeiro, que estão no áudio, talvez eu acho que eles estão nos vendo, mas nós não estamos vendo a eles. Não sei se eles têm condições de dar o áudio. Pessoal do Rio de Janeiro está nos ouvindo?
Sim, aqui é professor Seligman.
Sérgio Pinto Ribeiro, o professor Seligman está na minha frente. Então vocês estão percebendo a imagem aí com vocês, não?
Perfeitamente, muito bom.
Então tá, então...
Quem está falando agora é Ronaldo Monte. Eu tenho que ter na escrita a rede universitária de medicina. Estão presentes aqui o professor Billy Oigman, titular de médica da Faculdade de Ciências Médicas da UFRJ, o professor Marcos Brito Neves, que é chefe do departamento de clínica médica, e coordenador do programa de mestrado e doutorado de ciências médicas, e mais professores, alunos e residentes do departamento. É um prazer para nós.
Certo. Então, bem-vindos à rede e espero que tenhamos uma ótima sessão e no final da apresentação...
Bom, em nome do Serviço de Medicina Interna e do Serviço de Cardiologia, é uma honra ter o professor P.J. Devereaux aqui. Professor P.J., para quem não conhece, cardiologista e epidemiologista do Canadá, ele tem trabalhado ao longo dos anos com questões que respondem perguntas ou levantam perguntas que a gente tem, identificação precoce, identificação de infarto ou de eventos vasculares em pacientes em CTI, eventos vasculares em pacientes com insuficiência renal, conduziu um grande ensaio clínico que foi o POISE, mais comentado recentemente, o envolvimento do Otávio, parceiro aqui, e a gente está extremamente honrado de iniciar essa parceria, tentando identificar preditores de eventos vasculares e ver se essa identificação pode mudar também prognósticos. É um grande estudo, é o VISION, um estudo multicêntrico, no qual a clínica se insere numa parceria entre a cardio e a medicina interna. E ontem a gente estava comentando, o professor P.J. é presente desde em discussões sobre desfechos combinados, sobre tamanho amostral, ele tem participado de questões que fazem parte do dia a dia da gente, não só na questão epidemiológica, mas na discussão clínica e o quanto os achados têm repercussão clínica e o quanto a gente pode pôr a evidência na prática. Então, é extremamente honroso tê-lo aqui hoje e, sem mais delongas, passo a palavra para o professor.
Good morning. Can everyone hear me okay? In the back, I'm projecting okay. If at any time I speak too fast, please you can hold up your red card and tell me to slow down. I'm trying to embrace your South American culture, and so you're going to do some voting during the talk, so hang on to your cards. I just want to say what a privilege and honor it's been to be here the last day. We've had a great time meeting all the people involved with a study that we'll talk briefly about in this talk. And you have a very impressive hospital, and the staff I've all met have been very impressive. So thanks for the opportunity to be here, and I hope I'm able to convey to you today the importance of this area, which I personally feel very passionate about. So, first thing is, in our institution, we're expected to put up our disclosures before all of our talks. So I'm a member of a research group which has a policy of not accepting honorariums or other payments from industry for our own personal financial gain. We do, however, accept honorariums or other payments from industry to support research endeavors and for reimbursement of costs to participate in meetings such as scientific or advisory board meetings. Based on study questions I've originated and grants I've written, I've received grants from AstraZeneca, Bristol-Myers Squibb, Stryker, and Roche Diagnostics, and I've participated in advisory board meetings with GlaxoSmithKline and AstraZeneca. Okay, so my goal today is that I first want to talk to you about the magnitude of the problem, and by that I mean my whole talk will focus on non-cardiac surgery and major vascular events. And throughout the talk, when I say major vascular events, I specifically mean vascular death, non-fatal MI, non-fatal cardiac arrest, and non-fatal stroke. I'll then talk about methods to predict these events. I'll then talk to you about monitoring for perioperative MIs. And I'll then talk a bit about the vision study, which folks here are getting ready to start, and they've already run a pilot. And then I'll also talk to you about perioperative beta blockers. A group of us internationally with also important participation from Brazil recently had committed a large beta blocker trial, and I'll hope to share some of the insights I think we gained about beta blockers from that trial. So in terms of incidence, this is the first time you're going to vote. So the first question is, what do you think is the annual incidence of major vascular complications, once again, vascular death, non-fatal MI, non-fatal cardiac arrest, non-fatal stroke, among the 200 million, so I want to emphasize that again, 200 million adults have major non-cardiac surgery every year. So what do you think is the incidence of these major vascular complications among these 200 million? If you think it's 5 million, I want you to hold up your red card. If you think it's 1 million, I want you to hold up your yellow card. If you think it's 500,000, I want you to hold up both cards. And if you realize you're at the wrong talk, it'll now be time to leave. So, let's see people vote. What do you guys think is the incidence of major vascular events? Vote, vote, vote. Okay, so it appears that 45.5% of you believe that it is 5 million, and we have 54.5% that believe it is 1 million. Okay, so keep that in mind as we talk. Now, in terms of prior observational studies looking at the incidence of major vascular complications, and you look at the studies that enroll patients who either had coronary disease or risk factors for coronary disease, the incidence in general has been reported to be about 4% for a major vascular complication in the first 30 days. If you, however, take an unselected population and you take all comers, let's say age 45 or age 50, having non-cardiac surgery, importantly, this comes from work that Carisi was involved with and played a very important role with out of Boston. It suggests that the incidence is about 1.5% for a major vascular complication. So if that was true, and let's just say of the 200 million adults globally who have major non-cardiac surgery, that about half are in age 45 or greater, and based on some of our research, it's likely in that range, that would mean that about 1.5 million adults would have a major vascular complication annually, if that was true. There's major limitations to this, though. All this data is old data. First off, the study from the Revised Cardiac Risk Index, that data now is about 15 years old. Most of the studies were single-center studies. Most of them had small sample sizes, and really importantly, the most common major vascular complication is myocardial infarction. And all the studies that I'm talking about here use CKMB to diagnose myocardial infarction. Now, there's two problems with CKMB. The first is what most people have written about. You can get false positives, so that if you did a hip replacement on a patient today, tomorrow the CK may be up not because of a heart attack, but because CKMB can be released by skeletal tissue trauma. We actually think there's a much bigger problem, though, which is false negatives. And the problem why you can get false negatives with CKMB is that the vast majority of heart attacks, which I'll show you a little later on, will occur in the first 48 hours after surgery. So in order to get a CK-MB relative index over 4%, when the first 2 days you have a lot of CK floating around from surgical trauma, because if you do, like, let's say open AAA today, tomorrow you have a lot of CK floating around from the surgical trauma. You have to have a very large infarct in order to overcome the dilutional problem of the surgical CK that's floating around. So the truth is, we actually think a lot of MIs were missed in the past because of timing and dilutional problems because we relied on CK-MB. Now that we use troponin, there is no dilutional problem, and that may actually shift what's happening in terms of the incidence. Now, interesting enough, most people who actually are writing about perioperative events say the event rates are dropping. I'm going to put forward to you in a moment, I believe they're actually rising. So in terms of current studies, we've undertaken the Vision Pilot Study, which is a prospective cohort study, patients who underwent non-cardiac surgery. All they had to be was age 45 or greater, having a non-cardiac surgery that gave them a general or regional anesthetic, and that they stayed in the hospital overnight for. So we didn't select only vascular patients or thoracic. We took all comers. It could be obstetrics, gynecology. And consecutive sample, night cases, day cases, weekend cases. In this pilot, we had 361 consecutive consenting patients from 4 countries. Now, I haven't yet included the Brazilian data from your site because it just finished, but I'll tell you from what I've already seen, essentially what I'm going to show you is actually what you saw here. The 30-day incidence of major vascular events, we had 28 events, which gave an 8% incidence. Now, the first thing I just want to highlight is that it's a very small sample size. I would not draw any firm conclusions from it, but it certainly looks very different than the 1.5% that I just showed you a moment ago. And I can tell you I already know from the POISE trial, which I'll talk a bit about in a moment, the incidence is definitely rising. And I think it's rising because we've gotten reasonably good at treating acute coronary syndromes in the emergency room. We've gotten reasonably good at treating heart failure. We've gotten reasonably good at treating patients with serious arrhythmias. And all those patients are now living. And they're living long enough to get bad hips, bad knees, and colon cancer. And there's also been a societal shift towards advanced care for the elderly, including surgery. So the upshot is much older patients, much higher burdens of vascular disease, having surgery, and I put forward to you that surgery is the ultimate stress test. Despite all the good that surgery does, it creates the perfect milieu for vascular complications. And that's why I think we're seeing a rise in the actual event rate. And I predict it will continue to rise because we're going to continue to do surgery on older and older patients. Now, I still put forward to you that the current incidence, it is substantial, but there is uncertainty. The old data is unreliable. The Vision Pilot Study is just too small. It has to be replicated. There is a need for a large study with multiple hospitals, both universities and community hospitals, in many countries. And the truth is, we have as much to learn from Brazil as hopefully we have to offer Brazil. And the same is true with India. And it's only by coming together to tackle these problems can we have reliable sample sizes to allow us to address questions. It's another talk, and perhaps another time when I am here I could talk about it. I think that there's a fundamental problem that occurs in current research based on statistics, that there's another metric that people yet don't understand, which is fragility. And oftentimes our research, which looks like it has very profound p-values that look very significant, you can flip them by adding a few events. And it's fragile. And so the truth is we need to all come together to address these problems. And further, health is global and we all have a lot to learn from each other. Knowing the incidence is important. It's important because it will inform the resources required to address the problem. And let's just say that the pilot, the event rate is actually half of what we saw in the pilot. Let's say it is 4%. If it is 4%, what this means is that at least 4 million adults annually would suffer a major vascular complication around the time of surgery. What is important to realize is that that is in the range of how many people acquire HIV every year. Now, the reason I put up the analogy to HIV is for 2 reasons. The first is that there is no doubt that HIV is an enormous population issue confronting our planet. If major vascular complications around the time of surgery have an equal incidence, it also highlights it is equally a very serious event that's happening to our populations. Further, HIV in many ways is incredibly remarkable about what we can accomplish in research. We went from a sure death sentence in a span of less than 20 years to a chronic disease. Now, it's a chronic disease that none of us want, and I'm not trying to downplay how serious it is, but it shows the incredible progress we can make in science if we have all of us come together, if we put enormous resources on it, and if we put our focus on it. The truth is, I put forward to you, we could be 20 years from now with perioperative vascular events where we are today with acute coronary syndromes in the emergency room if we all come together and we rapidly address it the same way that HIV has been addressed. But I put forward to you that I actually believe major vascular complications around the time of non-cardiac surgery represents the largest emerging epidemic within cardiology. I'll also explain why in a moment. Although all of you, I have no doubt, think perioperative events are an issue, I suspect you're thinking, it seems like I'm overstating it. It seems like it's not this big an issue. I'll explain to you in a few moments why, in fact, I think most people underappreciate how big a problem it actually is. Now, in terms of predicting perioperative cardiovascular events, in general, there's been two approaches. There can be a generic model, and here's various generic models listed here that exist. And generic models basically work by saying there's a patient who's age 70, who's had a history of heart failure, and hence they're going to have risk X when they have surgery. Another approach is Bayesian models. And what Bayesian models do is they start off by saying, in our institution, someone who's going to get an open colectomy done, their baseline risk is X. And then what it does is it incorporates the patient factors by saying this patient is also age 80, they've had a history of coronary artery disease, and that gives them an index score for the individual of 10, and you use that index score to modify the average risk in your hospital to give that patient's individual risk. Bayesian models have only been tested in two circumstances relative to the generic models. They look superior, but lots of limitations in the studies. When doing it, though, the problem is no one knows their own baseline risks. Your institution doesn't know it. My institution doesn't know it. No one knows it. And if you don't know your baseline risk, you can't incorporate a Bayesian model. Further, in the end, Bayesian models will be superior if there are institutional important differences between us. So in other words, if I fell and fractured my hip and had surgery done here today, maybe I have a different outcome if I fell and fractured my hip and I had it done in Buenos Aires. If there's institutional differences that affect outcome, that will actually drive differences for Bayesian models. It highlights why we need large studies to figure out whether or not, in fact, the Bayesian is superior to the generic model, and also why each institution that participates in such a study has to contribute a lot of patients so you can understand the baseline risk at an institution. Now, in the Vision pilot study, I'll show you results from a single center, but it's consistent across all the centers. And the current model that most people advocate, and that's been most well studied, is the Revised Cardiac Risk Index. And this is the index that Carisi was involved with. And so in the Vision pilot study, this shows you the number of risk factors that patients had. This is the event rate that we saw for major vascular complications. And this is the event rate that we expected according to the Revised Cardiac Risk Index. So what you can see is when we saw one risk factor, we had a 7% incidence. We expected a 1% incidence. When we had two risk factors, we had a 17% incidence. We expected a 2.4% incidence. When we had three or more risk factors, we saw a 37% incidence. We expected a 5% incidence. Now, lots of caution because the pilot is small sample sizes. That being said, I can tell you from the POISE trial where we have 8,351 patients from 190 centers in 23 countries, the Revised Cardiac Risk Index, the factors matter, but they substantially underestimate risk. In general, what I tell my residents and what I do in the short term is that I multiply the Revised Cardiac Risk Index score by at least about 3 in terms of the incidence. I can't tell you what's absolutely right, but that's probably closer to the ballpark of what is the reality of people having non-cardiac surgery today. Now, the next issue is that will clinical risk indices I put forward, they're not likely ever to be enough. I put forward that they'll be insufficient. And the reason that I put forward that they'll be insufficient is because of this picture. The reality is a lot of our patients who we see prior to surgery, the patients, when we ask them, do you get chest pain? Do you get shortness of breath? And the patients say no. The problem is they're a lot like these guys in this picture. They're not doing anything. So the problem is a lot of times they may be sitting on very significant disease, but because they're not active at all, you may underestimate the disease. And so that's true for our orthopedic patients. It's true for our vascular patients. It's very commonly true for our cancer patients, which represent an enormous population of the people having non-cardiac surgery. So my suspicion is, yes, we can build a better clinical model, but we're likely going to need additional information to help us with a lot of our patients who are inactive. Now, this is a meta-analysis that we have just coming out in publication looking at measuring BMP prior to non-cardiac surgery. Now, to get into this meta-analysis, the participants in the study had to have a BMP measure prior to surgery, and they had to look to see whether or not that BMP measurement was an independent predictor of a major vascular event in the first 30 days. So in other words, they had to adjust for other known predictors. That's what they had to do to get into the study. Now, most of these studies use NT-proBNP. And these studies, do they have limitations? Unequivocally. Do they adjust for all the risk factors? No. Are their models potentially overfitted? Absolutely. Nonetheless, the signal is actually quite striking. So this is showing you the odds ratio for each study, and what you see is that every study that's looked at BMP as a preoperative predictor, independent, suggests that it is an independent predictor. When we pool the results, the odds ratio is 19. That suggests that a BMP being elevated prior to non-cardiac surgery is a profound predictor of who's going to have an event. What's also very interesting about this, 25% of the patients in the studies had elevated BMP. So it's not that it occurs in 1 in 1,000 patients. If in fact this is true, this would be an incredibly helpful tool that is relatively cheap, extremely rapid to get, to help enhance risk prediction. I don't know what it's going to turn out to be. I'd be very surprised if it's not a strong independent predictor. I don't know if it's going to be an odds ratio of 19 or 10, but even if it's 10, it is still a profound predictor of what's happening here, relative to non-invasive tests, what I'll talk about in a moment. So now, in terms of the next question for non-invasive tests, do you believe that there is good evidence supporting preoperative non-invasive tests, cardiovascular non-invasive tests? If you do, I want you to hold up your red card. If you don't, I want you to hold up your yellow card. And if you think it's sacrilege even to ask such a question, I want you to hold up both cards. I'll assume the nuclear cardiologist in the room will hold up both. So let's see you vote. Do you think there's good evidence for this? This is a great audience. I love when everyone's completely split. Now, there's one honest cardiologist who does nuclear medicine clearly here who says sacrilege, but you're pretty much split saying there's good evidence or not. I'll put forward to you that, well, one of the great privileges I've had in the last 6 years with our research program is traveling a lot of the world, and I'll always ask people this type of question, and I'll show you some other questions I ask in a moment. And in general, using non-invasive tests, especially for vascular surgery patients, is extremely common. I'll be surprised if in your institution you're not doing it on the majority of patients. I think it's extremely common. So I'll now show you the evidence around it. So one of the things, even as cardiologists, and definitely everyone else in medicine is guilty of, there is a tendency to treat nuclear studies as dichotomous. They're positive or they're negative. And clearly I think it's a way too simplistic view of the test results. In general, if the test is positive, that starts a path. You're going to the cath lab. And it doesn't matter how positive, you're going to the cath lab, and you're going to the cath lab for one reason. If there's a lesion, someone's going to blow it up. So it starts this chain of events. So what's interesting is, and this is a meta-analysis done by Ed Etchells from Toronto, they look to see, based upon the amount of myocardium showing ischemia, how that affected the actual probability of a major vascular event. In this meta-analysis, the outcome is cardiovascular death and MI at 30 days, okay? So what you see here is that when patients have no defect, the likelihood ratio is 0.42. Now, for those of you who may not be that familiar with likelihood ratios, a likelihood ratio of 1 is a test which is useless. The pre-test probability is equal to the post-test probability. As you get less than 1, that's making the event less likely. 0.42 is okay. That's not super strong. And what is interesting is that about 30% of patients that will have a normal stress nuke study or even stress echo study will in fact go on to have a perioperative MI. 30%. Now, 30% of patients are going to get this scan result. If if we start off by saying that people having vascular surgery have a 7% incidence of a major vascular event, what this would do is it would shift the 7% with this test result down to 3%. However, the confidence boundary is up to 6%. I think we tend to have a real sense of incredible relief. The stress nuke is normal, and it's like the patient now is, bulletproof. It actually is probably shifting the risk somewhat, but it's probably not remotely as dramatic as what most people actually predict. What is interesting is, in fixed defects, it overclaps 1. It's probably somewhere around 1. If you have reversibility less than 20%, or even reversibility that's 20 to 29%, the likelihood ratio is 1.3 to 1.6. It's an extremely small likelihood ratio. Your pretest probability of 7 would only go to 9, and it overlaps 7. It may not actually add anything. And what's interesting is the most common positive stress nuke result is less than 20% or 20 to 29%. These patients, I put forward to you that someone gets a stress nuke done, they show some inferior ischemia. Once again, most of those patients are heading off to the cath lab. Their risk of an event is negligible, if not at all different from whether they did or didn't have this study before they had the test done. It has small impact. That being said, certainly when you get up to, let's say, 30% plus, your likelihood ratio is about 3. So your pretest would go from 7 to about 18. But only 6% of people get this study result. Only 3% get this one. And it's only once you really hit greater than 50% or 50%, your likelihood ratio jumps to 11. So you go from a pretest probability of 7 all the way up to 45, but only 3% of people get this result. I'm not trying to say that stress nuke studies are not of value, and I certainly order them myself in some patients. But I think we should actually be very clear about the power of this study. And further, I want to make one other point very clear. The data I'm showing you right here is not independent information beyond clinical information. This is just showing you the raw association. It is possible that, in fact, with the clinical information, and it is for certain with the clinical information, these results are not as dramatic. They, in fact, may disappear for a number of these events. Because the truth is, we only want to do the non-invasive test if it has additive, independent prognostic information, not if it just reconfirms what we can tell clinically. So the current state of knowledge, the clinical risk factors in the revised cardiac risk index, they matter. There is no question. Those risk factors matter, and they're relatively straightforward, and they're obvious risk factors. But the model does underestimate risk. Preoperative NT-proBNP appears very promising. The non-invasive tests do predict, but how much information they provide beyond clinical information requires further research. And further, I just think we have to get out of the mode of treating the non-invasive tests as dichotomous tests, positive, negative. We've got to think about the amount of myocardium involved and whether or not, in fact, a big risk is actually being likely present. Now, perioperative MIs. We've undertaken a systematic review looking for studies that had reported patients who had perioperative MIs and reported whether or not the patients did or didn't have symptoms, or they could provide us with that data. So we only found 3 studies that met our criteria, so lots of limitation. Only 1,300 patients included, only 38 MIs. So reservations about conclusions. What is so striking, though, about the results is that only 16% of patients had chest pain. This is obviously an incredible contrast to what you and I see every day when we get called to emerge for acute coronary syndromes, where 85% plus of people are going to have some form of chest discomfort. It looks like a majority of people will not have chest discomfort. And even if you talk about any signs or symptoms, including tachycardia, hypotension, which doesn't mean that the average surgeon will first jump to thinking about an MI when a patient is tachycardic, because there's a lot more other explanations that may be present, you're still at about 50%. In the POISE trial, we had 415 patients, that is 5% of the patient population, suffer a perioperative MI. In the POISE trial, 2/3 of patients did not have ischemic symptoms. Now, in the POISE trial, we systematically measured troponin sometime between 6 to 12 hours post-op and then day 1, day 2, day 3 post-op. If we hadn't measured troponin, we would have likely missed 2/3 of the MIs. Now, the patients with troponin elevation had to have also either ECG changes or echo changes to meet the definition of MI if they didn't have symptoms. 3/4 of the MIs that actually occurred happened in the first 48 hours after surgery. We think this explains why the majority are asymptomatic. The majority of people, when they're suffering their MI, are getting high-dose analgesic medication. You can imagine that if you're getting enough analgesic medication to blunt the discomfort from having someone rip out your hip and put a new one in, it's probably not that shocking that you may not experience chest pain when you suffer an MI. So I think the thing we have to recognize about perioperative MIs is that they look different than our MIs that we see every day in Emerge. And because they look different does not mean that they're less important. And I'm going to talk about how important they are in one moment. Okay, now for the relevance of the perioperative MI. Does an elevated troponin after surgery matter? So if you think it matters, I want you to hold up your red card. If you don't think it matters, I want you to hold up your yellow card. And if you think it's only if it's your elevated troponin that matters, I want you to hold up both cards. Okay, so a relative sea of red, which is consistent with the rest of the planet. Now, because of time, I didn't ask the other question. I usually ask people a question, do you measure troponins, routinely peri-op? And the universal answer is no. And then I ask the question, do you think it matters? Absolutely. So there's always this contrast. That being said, I'm still not saying what's the right thing to do, but I'll tell you more in a moment. Okay, another systematic review that we've undertaken is that we looked at studies where patients underwent non-cardiac surgery and they had to have at least one troponin measured after surgery. And they had to look to see if that troponin elevation was an independent predictor the patient would die in the next year. Okay? So ideally they adjust for hypertension, smoking, etc. Did the studies optimally adjust? Absolutely not. Are the limitations study? Unequivocally yes. That being said, it's a very interesting signal. Well, you see of all the studies that up to 1 year, looking at death, looked at this, you see that the pooled analysis with zero heterogeneity suggests that there's a 6-fold increase in your patient's probability of dying in the next year if they get an elevation of the troponin after surgery. This suggests that these troponin values matter a lot. So once again, I just caution people that you see a lot of people write in notes troponitis and they keep walking. That may not be doing our patients a service. These events look like they matter a lot. Now, in the POISE trial, what do we see? The 30-day mortality rate in patients who suffered an MI was 11.6%. What's interesting about that is that's almost double the death rate at 30 days of acute coronary syndrome in the emergency room. The perioperative MIs look like they actually have a much worse outcome than everyone that we treat every day. So when I'm 100% certain, like in my institution, when people show up in your emergency room with acute coronary syndrome, people jump all over them, and lots of things are going to be done to that patient. This population that has an MI, I put forward to you, for the most part, most of us don't pick it up, and when we pick it up, for the most part, they're ignored. They appear to have a double the mortality rate in 30 days, which raises a very important issue about our current management of surgical patients. The patients who didn't suffer an MI in the POISE trial, 2.2% were dead at 30 days. MI, once again, appears to be a very profound predictor of whether or not people will die in the next 30 days. Now, the issue is it independent? So in the POISE trial, we put in a multivariable analysis the perioperative events that happened, and both symptomatic and asymptomatic myocardial infarctions were independent predictors the patient would die within 30 days. Forget a year, just within 30 days. And they were equal, suggesting that it didn't matter if the patient had ischemic symptoms or not. Their probability of being dead in the next 30 days, you were increasing it about 3.5-fold. So it appears that these are very important events. So our current knowledge regarding perioperative MIs. A substantial proportion of MIs are clinically silent. Perioperative MIs appear to negatively impact prognosis, both in the short and intermediate time. Monitoring for troponins post-op has potential to help physicians avoid missing MIs. Elevated troponins, whether associated with symptoms or not, appear to carry an important negative prognosis. And I think, personally, one of the great tragedies I think that is happening globally is that there's times when surgeons are curing cancer. There's times when surgeons are giving patients a new lease on life by peripheral vascular surgery, a new knee, whatever. And some of those patients are suffering vascular events, which either they're not detected, or they get detected and they don't get managed. And these patients, unfortunately, don't survive, in the intermediate term to actually enjoy the benefits of that surgery. I think there's no question we've made important advances throughout the last 20 years in surgery and in anesthesia. Where we have failed to make advances is in the medical management of this patient population, and it is an enormous population. And we owe it to our societies to do a better job and sort this huge population problem out. I'm going to tell you a bit about the VISION study. So the VISION study is a prospective cohort study of 40,000 patients. The eligibility criteria are that patients have to be age 45 or greater, undergoing non-cardiac surgery requiring overnight hospital admission, and will receive a general or regional anesthetic. Participating countries are Brazil, Canada, Chile, China, Colombia, India, Malaysia, and Spain. Patient follow-up, all patients, everyone in this trial is getting troponin T. And the reason it's troponin T is that obviously there's a lot of issues with eye in the sense that there's at least 12 troponin eyes out there, and hence there's not standardization across eyes of thresholds. Troponin T is patented, and there's a single troponin T. So we'll be able to see in the 40,000 patients, we'll be able to figure out thresholds of troponin that matter to actually independently change prognosis. So everyone will have troponin T drawn sometime between 6 to 12 hours post-op and then day 1, day 2, day 3 post-op. If a patient has an elevated troponin, they then get an ECG. One caution that I want to bring to people's attention, a lot of times the first ECG is normal. The reason is by the time you pick up the elevated troponin, you may be 20 hours past the MI. And what you frequently see is the next day T-wave inversion or the day after. So don't be startled when you don't see T-wave or you don't see ST changes when you first pick up that troponin elevation. If patients don't have ECG changes, then we recommend to get the echo. The other thing is, why we recommend the echo is, to be clear, is there a wall motion abnormality or not? And sometimes we've also picked up as silent PEs. Clearly we'd like to know, are we either in the MI category or the PE category because they have important implications in terms of treatment. Research personnel then follow patients throughout the hospital course in contact at 30 days and 1 year, and they note any primary or secondary endpoints. The current status is that we've recruited over 10,000 patients in 6 countries, and obviously I'm very happy to have and delighted that your center is going to participate. One thing I want to make clear is that Vision is set up essentially as a data sharing program. The 4 primary questions we'll publish under group authorship, but every center that participates has to include at least 2,000 patients, and they can include upwards of 4,000. For doing that, though, each center leads at least one major sub-study of 40,000 patients globally. Further, there's many sub-studies which, in fact, there'll be individuals from each center that will participate in. So that, in other words, you will not only know what's happening in your own center, you will not only be able to publish your own data from your own center and even nationally, but you guys will lead a study of 40,000 patients international. There's no question it's real work. There's no question the data has to be accurate. There'll be tough monitoring. But, once again, I think the upsides are very large for what, in fact, can be brought out of this. Currently, we have over 30 funding sources. One of the challenges with large observational studies, and I've spent basically the last 4 years of my life writing grants for Vision, is that it's hard to get enough funding for these large studies. And we've had to get studies in many grants in many countries, and we've gotten an endless amount of sub-studies. So we're doing sub-studies on things like coronary CT angiography prior to non-cardiac surgery. We're doing sub-studies, about 10,000 patients are getting NT-proBNP measured prior to non-cardiac surgery. We're measuring, creating a biobank. We're looking at thrombotic, platelet, metabolic, inflammatory, genetic factors. What are the influences prior to surgery and then what happens post-surgery? We're looking at also renal issues and trying to come up with better measures to quickly pick up acute kidney injury. We're also trying to find a troponin for the brain. There's a whole lot of things to look at in this biobank. And as I said, we're also doing a sub-study. We're measuring coronary CT angiography prior to non-cardiac surgery. Now, for the last topic I'll cover is perioperative beta blockers. Before I cover this, I do want to say this one point, is that our group, we did do the largest beta blocker trial in this area, but there's a lot of things I learned from doing this trial, of which you'll see in a few moments. I think one of the lessons I learned is despite the fact that it's large, I think we should be humble about our research in that it rarely tells us the truth. POISE does not answer all the perioperative beta blocker questions. That being said, I do actually think it provides some really important insights to help you manage your patients. So, the last thing you're going to vote on is, based upon your current evidence, do you start perioperative beta blocker therapy in your patients with or at risk of atherosclerotic disease who are undergoing non-cardiac surgery? If you do, I want you to hold up your red card. If you don't, I want you to hold up your yellow card. And if you say yes, but you feel like you want to be polite and say no, you can hold up both cards. Okay, so let's see people vote. Who starts beta blockers? Cards, cards, cards. Vote, vote, vote. Vote. Okay, so actually a dominance of people voting are saying they do start beta blockers. All right, okay. I'm glad that people feel liberated to say what they want. This is the right thing to do. Okay, so the POISE trial. So the POISE trial was a randomized controlled trial. We had blinding of patients, healthcare providers, data collectors, and outcome adjudicators. And to get in the trial, the patients had to be age 45 or greater, essentially have atherosclerotic disease or risk factors for it, and be staying overnight, at least overnight in hospital. The intervention was metoprolol CR or matching placebo, started 2 to 4 hours before surgery, and then continuing for 30 days post. Now, the way that we dosed metoprolol CR was 2 to 4 hours before surgery, we gave 100 milligrams, and then 6 hours after surgery, we gave another 100 milligrams. And then after that, starting the next essentially 24 hours after the first dose, we started on 200 milligrams once a day. Our goal was to try to get 200 milligrams of metoprolol CR into patients in a 24-hour period. Now, if patients had a systolic blood pressure less than 100, they did not get the drug, and they actually dropped down to 100 milligrams once a day. If patients had heart rates less than 55, they did not get the study drug. If, in fact, their heart rate got less than 45, once again, they dropped down to 100 milligrams once a day. If they couldn't take oral metoprolol, they took IV metoprolol, 15 milligrams and 25 cc's of normal saline, infused over an hour, heart rate, blood pressure checked 10, 30, 60 minutes into infusion. If dropped below parameters, infusion was stopped, subsequent doses dropped. And I'll talk more about the dose a little later on. The main outcome measure was a 30-day composite of cardiovascular death, non-fatal MI, and non-fatal cardiac arrest. In this trial, we randomized just under 9,300 patients, half to beta blocker, half to placebo. Now, we have the most unfortunate experience that I hope none of you ever have of actually discovering fraud in some centers. So when we discovered fraud, I went to these centers. I'll tell you more about the fraud in a moment, but when we discovered fraud, I came back from monitoring these centers. We met, the operations committee met. We decided that without knowing the results of this center, without knowing the results in the overall trial, that these centers, these patients' data would be excluded. We then presented that to the Data Safety Monitoring Board, who agreed. We then presented to our funders, who was the Canadian Institute of Health Research, to multiple ethics boards, and I spent about 3 months of my life dealing with this issue. So in the end, we came down to having 4,174 patients in the beta blocker group, 4,177 patients in the placebo group. 8 patients did not complete the 30-day follow-up in the beta blocker group, 12 in the placebo group, which meant that 99.8% of the patients completed the actual 30-day follow-up, and we undertook analysis according to the intention to treat principle. Now, overall, we have included 8,351 patients in 190 sites in 23 countries, and as you can see, we had very good representation from Central South America. They played a very important role in this trial, and I can't, thank people enough for the contribution that they did make. Now, I did say to you that we discovered fraud, and a very legitimate question that you should ask yourself is the rest of the data valid? I'd be a fool to not suggest that that's not a valid question. It is. I will suggest to you that I actually believe the rest of the data is valid, and I'll explain why now, but obviously you'll have to make your own decision, if you believe that is true. So at the start of this trial, we were doing what most clinical trials do, and certainly what we were doing in our center in our large trials, is we did central data consistency checks. So as an example, as people collect data on the patient, they fax it into our system, and it's instantly uploaded into our database. There's lots of checks across. So as an example, if a patient had been checked off as being greater than age 70 as one of their eligibility criteria, but their date of birth does not match that, a quality check happens that says, what's the inconsistency? After a certain number of inconsistencies happen at a center level, that triggers monitoring of that center outside of other monitoring that we do. How we picked up these problems was essentially through things that were missing or inconsistencies that we saw in the central data consistency checks. In the end, that's how the fraud came to light, but I went to the centers and we confirmed it. We also did, at the time that we discovered this, people were starting to publish on statistical monitoring. And statistical monitoring is probably the strongest tool to detect both fraud and error. And the reason I say that is that what you can do is you can look across time. So let's just say patients have heart rates and blood pressures measured across time in a study. You can look to see how those heart rates and blood pressures vary by center. And what you realize is that people making up data, it's very difficult to make data to look like the real world, because the real world is not random. The real world follows patterns. And so what you see is people who are making up data, they actually stand out when you do statistical monitoring. In fact, it's probably our strongest tool to detect both error and fraud. Now, if you detect that someone stands out, it doesn't mean it's fraud, and it doesn't mean it's even error. They may be different, but you have to go evaluate it to see why do they stand out. We finally did on-site monitoring. So we did on-site monitoring for all centers that recruited 40 or more patients and all centers that stood out on statistical monitoring. So we ended up doing on-site monitoring for 560 patients that came from 77 hospitals and randomized 85% of the patients, and they had 88% of the primary events. And outside of the mentioned cases of fraud, there was no significant inconsistencies with the data at the sites that we monitored. And for that reason, I do believe it's valid. But once again, you'll obviously have to make your own judgment. I think POISE does tell us another very important message, though. Sadly, fraud is a reality that happens. I think it's a minority of people. I don't want to tell people that I think this is a rampant problem. But at the same time, I think we have to take a very proactive and very strong stance on it, that in the end, in research, credibility is the only thing we have. Once you lose it, it's the end of it. So I think we should take a very strong stance that when it happens, we should be forthright about it, we should tell people about it, and that should be the end of those people being involved in the research. Okay, some baseline characteristics in POISE. The baseline age was essentially 69. So once again, a universal phenomena, we're doing surgery on much older patients. So essentially half the patients getting in are age 70 or greater. Baseline heart rate, 78 beats per minute. Baseline blood pressure, essentially 139 and 78. This is important. If, in fact, beta blockers were going to work in terms of physiological properties that we thought, we were starting off with a really good patient population. This patient was not bradycardic hypotensive starting. This patient population was predisposed towards tachycardia and hypertension at the start. So if the drug was going to work, this was a good population for us to study. 82% of the participants did have some form of atherosclerotic disease, that is either carotid, coronary, or peripheral. Now, I'll remind you once again that our a priori primary endpoint was a composite of cardiovascular death, non-fatal MI, non-fatal stroke. And what we saw is that with beta blockers, this went down. So the beta blockers, there was 244 patients in the treatment group who suffered this event, whereas there was 290 in the placebo group. So I was the first person to come unblinded in POISE, and I first saw this first page, and I'm like, woo! I saw the next one, and I realized that the signal was completely driven by a reduction in non-fatal MIs. I think there is no question perioperative beta blockers prevent perioperative MIs. The signal is clear. There is enough data where we can, I think, clearly state that that is very confident data. So 152 patients in the metoprolol group had a non-fatal MI, 250 in the placebo group, a 30% reduction, a result which is highly statistically significant. So once again, perioperative beta blockers do good. They prevent perioperative MIs. When I next flipped the page, though, I came to some of our secondary endpoints. And the first one I saw was total mortality. Total mortality went up with perioperative beta blockers. 129 in the metoprolol group, 97 in the placebo group, a result which is statistically significant. My first thought when I saw this result was I thought this, despite the fact it's a large trial, despite the fact there's a moderate number of deaths, my first thought was this must be chance. Because I thought we're preventing MIs, which I know matter, so how is it that we would have drove up death? That was my first thought. I now believe it's likely a true signal. I'll explain why in a moment, but that was my first thought. The next thing I saw really had me nervous. Stroke. 41 in the metoprolol group, 19 in the placebo group, a doubling of risk, a result which is highly statistically significant. So that certainly made me step back and say, what's happening here? Now, I assume since we were completely startled, I suspect most of the people involved with perioperative medicine were surprised by our results. What is interesting is, though, that a meta-analysis published just late last fall in The Lancet, when it looks at all the high-quality trials, what is interesting is, although it's dominated by POISE, no question, because it's so much larger than everything else, the high-quality trials suggest the same signals. So the high-quality trials are consistent, suggesting that, in fact, there is an excess of death. They also are extremely consistent in saying that there is an excess of stroke. In fact, there is not a single beta blocker randomized control trial that has happened where there's been a stroke and there's not been an excess of strokes in the beta blocker group. Now, most of the trials are not significant because they're too small, but every one of them are showing the exact same signal. There is zero heterogeneity, and the signal is very consistent across it. I think even though there's still, only a moderate number of overall strokes, the consistency of the signal, the strength of the signal makes it, I think, highly believable that, in fact, there is an excess of strokes with perioperative beta blockers. I'll remind you at this point, the strokes in the POISE trial were devastating strokes. The patients who had a stroke, a third of them were dead within 30 days. Of those who survived, 60% were either incapacitated or needing help with everyday activities. They were devastating strokes. You have to put that in juxtaposition to the MIs. 2/3 of people didn't know they had an MI. It doesn't mean the MIs don't matter. They unequivocally matter because they will increase your likelihood of dying. But I'm just saying in terms of what, if we look and say that death's heading in the wrong direction, and then we're going to say, what about the non-fatal events? The strokes look a lot more devastating compared to the MI. So insights from the POISE trial regarding the negative outcomes. Certainly the biggest thing we said was, okay, even though it's a large trial, it's still possible as a chance effect despite the statistical significance. How might this have happened? And I think once we started to look at some of the other secondary outcomes, it became obvious how, in fact, this happened. The big thing is hypotension. Now, we defined clinically significant hypotension as a systolic blood pressure less than 90 that someone did something about. We did not capture systolic blood pressure less than 90 that no one did anything about. We did not capture a systolic blood pressure that went from 190 to 95. And in many regards, I think in retrospect as a cardiologist, I was naive and cavalier about hypotension when we designed the POISE trial. And I think the reason I was, and I'll put forward to you and I want to caution you about not to make the same mistake I did, is that in general as cardiologists or internists, we may feel pretty comfortable that we can treat hypotension. And you got to remember, we're doing it in a setting of a CCU where there's very good nursing to patient ratio and there's people very attentive, they pick it up quickly, they let you know, and we can respond to it rapidly. These people have their hypotension not in the OR, because when they have it in the OR, the anesthetist is right there and they adjust the dose, and they're very adept at doing it. They have it on the surgical ward. And on the surgical ward, I put forward to you that the nursing ratio is such that it's typically a long delay to pick up the hypotension. Most of the patients are sedate the first 2 days, so they're not going to complain of anything. And even when they do pick it up, I put forward to you it's true in my center. I'd be surprised if it's not true in your center. The response to the hypotension is mitigated. Why? Because on most surgical floors, people typically are focused on wound management, diet, mobilization. Not because they're bad nurses, because like anything, I focus on what I've learned and what I think is important. They focus on what they've learned and what they think is important. So I think why we ran into trouble was because of the hypotension. Now, a couple of more points about hypotension. 10%, essentially 10% of the people in the placebo group got into clinically significant hypotension. It is incredibly common in the perioperative period. We're not talking about a rare event. And we increased it to 15% with the beta blockers. When we look to see then is whether or not the clinically significant hypotension was an independent predictor of death, it was the strongest independent predictor of death. It, in fact, had a hazard ratio of 5. So it suggested that if you got clinically significant hypotension, 5% more probable you're going to die in the next 30 days. Further, is that when you look at population attributable risk, it's a much more informative statistic than just simply what is the association, because it takes into account the strength of the association and how commonly it occurs. It tells you that potentially 37% of the deaths are explained independently by the patients who got clinically significant hypotension. So very common, very big impact. And when it came to stroke, the hypotension, twofold increase in the probability of having the stroke, about 15% of the population attributable risk. I think this, we can explain the vast majority of deaths in POISE. We cannot explain the vast majority of strokes. What I think, though, is the issue is we didn't capture, we were not expecting the hypotension to be as big a deal as we expected. So we only captured, once again, systolic blood pressure less than 90 that someone did something about. We didn't capture all the other blood pressures that likely mattered. So I think the signal in terms of the hypotension on stroke is even much worse. It's just buried in our, we didn't capture it. I want to just quickly tell you about the COMMIT trial because I think it is the exact same signal as POISE with one exception. The COMMIT trial is the largest beta blocker trial, randomized trial ever undertaken. Essentially 46,000 patients having acute myocardial infarction randomized to beta blocker or placebo. And in fact, we use their safety data, 10,000 patients into their trial, to help inform us around dosing that we use. Doesn't mean we're right on our dosing, but that's what we'd use based on their safety data. The outcome in COMMIT, I don't know if you were like me, but personally I was shocked. It was the surest way to fail your cardiology or internal medicine exams to say you weren't going to give a beta blocker an acute MI because you weren't going to save lives. COMMIT, no impact on death. I was shocked. What is interesting is, though, beta blockers do good. They prevented arrhythmic deaths, and they also prevented non-fatal MIs. But what did they do? They drove up shock death. They get an overall neutral balance because they're driving up shock death, even though they're preventing arrhythmic death, it's neutral. The difference with POISE is that shock was so much more common. Even though our beta blockers were doing good, preventing MIs of some which would lead to death, we had so much more shock state, we tipped the balance towards excess death. And I think that's why our signal in the end is not neutral on death, it is excess on death. And that, importantly, these people are being managed in a CCU setting. So it even tells you that there's patients that all of us get in that CCU where in fact if we get into enough hypotension, if you're on that beta blocker, you're in serious trouble. I think that's the bottom message line from both POISE and COMMIT. Beta blockers, no question, are beneficial drugs. They can do good. The problem is if you get into hypotension and you're on it, you're in serious trouble. Perioperatively, the hypotension is common. Frequently, it's not in a moderate setting, and that's why, in fact, it is such a dangerous outcome. Questions raised. Was the POISE dose too high? Very important question. The real question, though, is would a lower dose provide the same benefit and avoid the risks? POISE used metoprolol CR, a long-acting beta blocker, and targeted a dose that represents 50% of the maximum daily therapeutic dose. The two small positive beta blocker trials, of which represent 4% of the POISE sample. So in many ways, I sort of feel like we're in an area of science which is still, it's in its infancy both in terms of maturity of looking at science and not, because everyone wants to say, well, what about these small trials? They're so small that there's incredible fragility that it's crazy to think that they can be reliable results. But nonetheless, let's just take the results. And that the guidelines for the last decades that give beta blockers based on these trials. The first one, Mangano's trial, it used atenolol, a long-acting beta blocker. Fair enough, it's not as probably a long-acting beta blocker as metoprolol CR, but it's a long-acting beta blocker. They targeted 50% of the maximum daily therapeutic dose. What is interesting is, prior to POISE, when everyone on the planet said use beta blockers, no one was saying use beta blockers, but for God's sakes, don't use the dose in Mangano's trial because that's a crazy dose. Everyone was quite content to say completely reasonable dose and give these things. Once POISE came along, all of a sudden it became a crazy dose. The second one was by Poldemans. They used bisoprolol. Once again, a long-acting beta blocker. They started at 25% of the maximum daily therapeutic dose, but they allowed titration to 50%. About a third of their patients got to 50%. So there's no question. It is a lower overall dose than what we saw in POISE, and it is possible their positive result reflects their lower dose. However, it is extremely unlikely, and here's why. The next largest trial that's been published on beta blockers is DIPOM, 921 patients. They used metoprolol CR. They used half the dose we use in POISE. They used an overall lower dose than what Poldemans used. What do they show? Trend towards excess death, trend towards excess stroke. So once again, DIPOM certainly does not make it seem like it is probable. It's not impossible, but it doesn't make it seem probable that the lower dose will in fact result in safety. Possible, just not probable with the current evidence. Takeaway message from POISE. Patients who would place 3 times more value on avoiding a perioperative stroke compared to an MI or unwilling to accept a probable increase in mortality are probably unlikely to want a perioperative beta blocker. And one of the things I think that can happen in these things is that certainly can happen with all of us as researchers is that it becomes about us. It's not about us, it's about our patients. And the real issue is how would patients, what would they think of that trade-off? It's irrelevant what I think about it. The issue is how would the average patient say, I would accept this risk-benefit ratio. My own feeling is we've done a number of probability trade-off studies in AFib looking at stroke, death, or stroke bleeding. I've done it in looking at thrombolytics and acute MIs. Patients place unbelievable weight on avoiding strokes. Not that they want to have MIs, and the truth is, if I was in the survey, I'd be responding the exact same way. I want to avoid a stroke like the plague. So the issue is, if I do a 3-to-1 ratio, it's not a very attractive scenario. And further, when you throw in the mix that there's probable in excess of death, the average patient, I think, will look at us like we're insane. In fact, we've gotten funding to do a probability trade-off on this study, which we're going to do in Spain. It'll be very interesting. I think most patients will think, although, like anything, we have no absolute truths, I can't tell you a truth. Given this probable data, I think most people say, I don't see that as a very attractive trade-off, even though I don't want to have an MI. Guidelines have recommended perioperative beta blockers for a decade, even if 10% of physicians acted on the guidelines. And I can show you research that suggested 30, 40, 50%. There was a lot of hospitals that were actually being rated whether or not they were giving beta blockers. But even if just 10% had have done it, that means 100 million adults would have been given a beta blocker perioperatively throughout the last decade. If, and I want to emphasize, if the POISE results are applicable, the implication is that 800,000 patients died unnecessarily, and 500,000 had a major stroke unnecessarily. Now, once again, I could double the numbers. I can show you research that, once again, would easily suggest 20% got it. I could half the numbers. It doesn't matter. It looks like Iraq. You won't see it on the news every day like Iraq, but it looks like Iraq. And I put it up there to make a point. The truth is, although there's enormous potential for us to do good in medicine, and overall I think we do enormous good, We should not be naive enough to think that there's not potential to do very serious harm. And in cardiology, we've had more than our fair share of examples where we were convinced something worked, and then once we did large trials, we discovered not only did it not work, it actually was causing serious problems that we didn't appreciate. And I think why it highlights to us it is so crucial that we do large studies and that we have much more reliable evidence so that we don't make these kind of mistakes, and especially when you're in situations where there is such huge populations being treated. You know, when we do these kind of things in huge populations, the impacts can be so enormous. Could another beta blocker regimen provide benefit without substantial harm? Of course, anything is possible. Does the current evidence suggest it's probable? Not overly, but once again, all I would say to people is, we should do a trial and demonstrate it. You know, I think there's a number of approaches we can think about that might work, but until we show it, I just think it is cavalier to say, I know that if I do it this way, it's going to be okay. It's also cavalier to say, I'll do it, but I'll just tell people to watch for the hypotension. It's cavalier because we're not watching the patient 24 hours a day. These patients are on general surgical floors, and it's just a reality. They're not going to get that kind of intensive monitoring. So, you know, I think frequently we have to remove ourselves from, once again, it's my care and it's my patient, to what is the reality for these patients in terms of their actual management. There's hope. So despite what I just said, that beta blockers, despite the fact that they do benefit, but overall significant concerns about the harms, there is hope. So we've started the POISE-2 pilot, and we will be starting the full study before the end of the year. It's going to be 11,000 patients. It's a factorial design. It's a factorial of aspirin versus placebo. 2 strata of aspirin. Half the patients will be people who are on chronic aspirin, will be randomized to withdraw to placebo or continue low-dose aspirin peri-op. Half the patients will be patients aspirin naive, randomized to start aspirin or to go on to placebo. The second factorial is clonidine. We finished the meta-analysis looking at clonidine. What is interesting is there's always been more evidence for alpha-2 agonists than there ever was for beta blockers. We chose beta blockers for POISE-1 because we were a lot more familiar with it and a lot more evidence outside of the perioperative setting. With clonidine in our meta-analysis, if you actually use doses of 0.3 milligrams, less than 0.3 milligrams a day, the effect on hypotension looks dramatically less than what you see with actual beta blockers in that. Once again, would I hang my hat on this? Absolutely not, but I think there's enough encouraging evidence in terms of preventing the major vascular events and what looks like to be a low frequency of hypotension with low-dose clonidine. And further, your capacity to respond to the hypotension is very different because you're not blocking at the organ. That we feel encouraged enough that we are going to do clonidine. So patients are randomized to a 0.2 milligrams orally just prior to surgery, tablet of clonidine. A 0.2 milligram patch gets slapped on. It doesn't kick in for 24 hours. The patch stays on for 72 hours, then comes off. The aspirin is first dose, 2 81 milligram tablets, and then 81 milligrams a day post-op. For the people who are on chronic, it's 7 days post-op. People who are aspirin naive, it's 30 days post-op. So in conclusion, non-cardiac surgery is common. Despite the large number of surgeries, there still is uncertainty regarding the event rate, the best clinical model to predict risk. The proportion of MIs that are clinically silent and low is certainly substantial, but in a much broader population like vision, it'll be important to see is it's still in that range of 2/3. The prognostic significance of perioperative troponins, and importantly, the thresholds, and because we'll have 40,000 patients only with troponin T, we'll be able to figure out thresholds. The pilot study and systematic reviews provide the impetus for a large cohort study. The vision study and sub-studies will address many fundamental perioperative questions that will influence practice. And once again, I just want to say how impressed I was the last day meeting folks here and seeing just how bright and driven people were to make this happen. And as I said, by coming together, we'll really get some important answers. And further, you'll know exactly what's happening in your own institution. Further, just to let you know, in your pilot, I don't know if you shared this yet, in 1 week, you had 67 patients in. You had a 10% event rate of elevated troponins post-op. And if you hadn't measured them, you wouldn't have known this. So I'm telling you, it's not just an issue in other centers. It's an issue in every center. It's an issue in your center. There's need for large trials to evaluate prevention and management of perioperative cardiovascular events, and I look forward to hopefully a very long collaboration that is both directions and us sorting this out to help our patients for the future. Thanks very much. Oh, one last thing. I do need my cards back.
Thank you, Dr. Devereaux, for a nice presentation. Do you have time for questions?
Absolutely.
We are open for questions. Nossos colegas do Rio de Janeiro estão online? Parece que sim.
Então tomar em 5.
Alguma pergunta que os senhores queiram fazer?
Vamos um pouco mais da discussão. Vamos agora mais da discussão.
Eu não compreendi. Então, nós vamos...
Why are you not looking for a pulmonar emboli?
It's a question. Can you understand the question? You try. Eu queria agradecer, mas nós não estamos conseguindo entender as perguntas. Então nós vamos passar para as perguntas internas. Obrigado, pessoal do Rio de Janeiro. Professor Jorge.
I think the sound we had was from the beach. That was the wind. We were all concerned with the results of POISE, and of course you discussed the dosage of metoprolol, but we were also concerned about the timing you gave metoprolol. What are your thoughts about the timing? It's not the way we do. We give beta blockers to our patients several days in advance. We can titrate the dosage. And the final question, what is the plan for the clonidine study? Are you planning to start clonidine ahead or...
Great question on the timing. There's lots of questions, just because of time, I didn't put all of them in the slides. But actually, I have some slide on this. I have a slide directly on your question. So the question you raise is, would a beta blocker given earlier have a different outcome? I put forward is that the issue is not benefit. POISE shows you can start 2 to 4 hours before surgery. You'll get benefit. The only issue is safety. The truth is, you don't have to start 3 days ahead of time. You don't have to start 3 weeks ahead of time. You can give it 2 to 4 hours ahead of time. You will get the benefit of the MIs, but the issue is to starting it earlier, make it safer. So I think it's really important to be clear what is actually the question that is relevant to the timing. It's safety. Now, in the POISE trial, I can't tell you for certain if you start earlier, it may make it safer. My suspicion is it's low likelihood, and I'll explain why. The reason is, once again, 10% of people in the placebo group get into clinically significant hypotension. It's very common. Whatever dose you use pre-op, you're using it to say, this is the dose I think will be effective around the time of surgery. The problem is, whatever that dose is pre-op, it will not tell you what will be a safe dose post-op, because so many people get into clinically significant hypotension. So the truth is, the reason for starting it earlier is to say I'm going to be able to titrate it a bit to hopefully that I get a dose which is stable. It won't predict what will be stable post-op. Anything is possible, but it's for that reason I think it's probably low probability that by starting early you make it safe. You do not need to start earlier to get benefit. You can start just before surgery. The other thing is this, though. I put forward to you that there is a huge practicality of titrating. So you say that you start a beta blocker 3 days ahead of time. The issue is, if you start a beta blocker 3 days ahead of time, you're starting a single dose, because the truth is you're not going to see that patient, twice more before surgery. The truth is, when we talk about 200 million people and seeing them pre-op, and then we're going to titrate doses in these patients, I just don't think it's a practicality of what we confront in terms of medicine, because we wouldn't have the potential to bring all these people back for a couple of days in a row and say, how's your blood pressure doing, and let's titrate the dose further. Realistically, you're going to need more than a couple of days even to figure out what might be the stable dose in that patient. So is it possible? Yes. Is it probable? No, I think it's not. Further is that we chose protocols because the truth is, in clinical medicine, even when you talk about doing things that are simple, it's difficult to get it done. And the truth is, if we're going to talk about creating an efficacy-based type of protocol where there's intensive management and all kinds of titration, it'll be applicable to such a small population that just personally, that's not where my interests lie. I want to find things that'll be practical, effective, and safe for large populations. Now, the reason, once again, that in POISE 2 with clonidine, we're starting just before surgery. Our issue is, it's obvious from POISE 2, you can start just before surgery. You can get benefits. You don't need longer run-in. The issue is, will it be safe? We're encouraged, but far from convinced, based on the meta-analysis data, with the dosing we're choosing, which is very small dosing, and the difference in potential physiological response to hypotension, that hopefully we can get the benefits we saw but mitigate the risk. But we need a large trial to be confident. And I just think that the truth is going to be that for the next foreseeable future, it's not going to be simple to do large trials, and it's not going to be practical on a world scale, even if you show a benefit, if you're talking about starting interventions well in advance of surgery. Because the truth is, that's not the reality of how most people are seen prior to surgery. Most people are seen several days before surgery or a week at best. And I'd be surprised if your situation's a whole lot different here. And even if you are seeing then, you're going to be able to implement one drug, and then you're not going to have a chance to titrate it again. Whatever you start, it's going to be there.
Any other question? Then I thank you again for spending some time with us. And if you come back to Porto Alegre, we'll be here.
Great.
To
I will
enjoy
definitely
your presentation again.
I will definitely come back, and thanks so much once again. I really enjoyed meeting everyone here.
Thank you. Aos colegas do Rio de Janeiro, então, obrigado pela participação.